Hello nurses, this is Kevin with Nursing KAMP.com, and these are my scribble notes on nursing in the NCLEX. I'm continuing my series on cardiac telemetry, cardiac lecture number 46, shocking rhythms, to defibrillate or cardiovert. Cardioversion spelled wrong. Okay, from my sticky note found on Nursing KAMP, Instagram, Facebook, Pinterest, and Etsy. Follow me and say hello. So let's get into it. Okay, so the big key with these rhythms are there's two types of things. There's either a cardioversion or a defibrillation. So let's talk about the two differences. And when we're looking at these rhythms, each one's very specific to the outcome that you'll do. So let's go through the rhythms first. So the first rhythm that we have is we saw in our atrial rhythms, atrial fibrillation. Now atrial fibrillation is very specific because there is no P wave before every complex. So you generally have a patient who is fibrillating their atria because there's no SA node. And the SA node is responsible for the contraction of the atria to the ventricles, AV node. And what happens is that when somebody has AFib, they're at risk for having clots. Well, the interesting thing is that sometimes what happens is they'll be started on anticoagulants. They'll be started on heparin first, and then they'll be changed to like Coumadin, and we'll monitor their PT and INR. See my Coumadin heparin lecture on that. And sometimes, though, they might try to cardiovert them. And cardioversion is a method of giving somebody a shock, and it's an elective thing. So you cardiovert alive people. And that's the basic principle. It's an elective thing. They choose to get it. And what you're trying to do is you're going to try to increase the amplitude. And we'll talk a little bit more about that later, but so that you can shock them and hopefully maybe cardiovert to get their P wave started again. Now this is very specific to the patient's history and different things like that. So it's not everybody who gets AFib will be cardiovert. So that's a follow policy, but the big thing is that you can change that rhythm. Also the same thing with atrial flutter. Now flutter has these flutter cutter waves, and it's different than AFib because in AFib you have no P wave, but with flutter you have this conduction above the ventricle, and usually count these, and that's would be called 3-to-1 conduction, but there can be 4-to-1 conduction too. That means 4 flutter waves before every QRS complex. Well, these patients they're also alive and walking, and they could also be cardioverted. So they could be electively changed to hopefully maybe shock them to get that P wave functioning again. All right, the next one is SVT. In a previous lecture, we talked about SVT, and when we were talking about it, it's super fast, and so fast it's in the 180s to 280s ratio, where sinus tach is 100 to 140. So this is very fast, SVT. And generally we ask them to do vagal maneuvers first. So we do vagal first. If that doesn't work, then we do adenosine. And we talked about that in a previous lecture, where what adenosine does is it flatlines them. And then hopefully it just converts. And if that doesn't work, it goes back to SVT. They will add another 12 milligrams. Now, what if that doesn't work? That's where cardioversion comes in. And what they'll try to do is they're going to try to convert that rhythm. So they're going to try to, first they'll capture the R waves, and then they are going to shock and hopefully reset it. So generally the rule of thumb for adenosine is vagal, adenosine, and then cardiovert. The next thing is sustained Vtach. Well, what do I mean by sustained Vtach? Well, Vtach is a monomorphic rhythm where it's monomorphic, means it's the same. And with monomorphic, this is not a perfusing rhythm. So what happens is the ventricle is just fibrillating, okay? But it's pretty regular. And so these type of patients, depending on if they're alert, we might try to cardiovert them, okay? So it doesn't mean that this person is dead. Do they have a pulse? Are they looking at you? Okay. So the next thing we're going to look at is dead patients, okay, or patients without a pulse, and that's the big key with defibrillation. Shocking the patient, and the first rhythm that we're looking at with defibrillation is Vfib, and it's really chaotic, right? So it doesn't really quite make sense, and it's just real like this. This is a non-perfusing rhythm. This person won't have a pulse. And they're not going to be really aware of what's going on, so therefore they will be shocked. And hopefully to try to reset the heart. Get it out of this bad rhythm right here. Whoops. The next one is Vtach. Now we talked about sustained Vtach, and but these patients over here are alert, right? But for whatever reason, they're going into these runs, so they try to reset the heart with that. But other patients, if you see this on a monitor, monomorphic, and these patients are not perfusing, and there's no pulse. These patients are in a code, and you're probably doing CPR with these patients, and these patients need to be defibrillated. So we need to shock their heart. We'll talk a little bit more about defibrillation in the next lecture, but I'm just kind of going over the rhythms with cardioversion versus defibrillation. So that's it for Vtach. Remember, NCLEX really wants you just to be aware of what a rhythm might look like and whether or not it's shockable or not. And what does the patient look like? So you're always trying to look at what's the patient look like. Never treat just the rhythm. All right, the next one is Torsades. And Torsades is called Polymorphic Vtach. And it basically is rhythmic. So you see this kind of rhythm, and that's Polymorphic Vtach. This is acute, and it's usually because of low magnesium. And a lot of times patients, a lot of diuretics and stuff like that, they get hypomagnesia. And the treatment for hypomagnesemia is treat the underlying cause, 1 to 2 grams of magnesium. In the next one, I'm going to talk about so you might also shock that. That's depending on policy. The patient is decompensating and the mag isn't working. You can try to shock that rhythm as well. But the first treatment would generally be magnesium. That's why it's on a crash cart. And the last thing I'm going to talk about is what's called H's and T's, and that's going to be the next lecture. So that's about it for cardioversion versus defibrillation. So some overview is you cardiovert elective, alert people, and you defibrillate or shock dead people, people without a pulse, and you try to convert their rhythm. Where a person who's being cardioverted will walk into the office to have that rhythm change, where the person who is having a code doesn't know you walked into their office and you shocked them. Well, that's about it. My name is Camp, and this is Nursing Camp. I'll be covering the H's and T's in the next lecture, and go a little bit more into defibrillation versus cardioversion.